As I was saying, my name's Shabini. I'm the BUSOG Pre-Specialty lead on the National Committee. Welcome to our first event. We're going to be looking at career options in O&G after foundation training. My role this year has been focused on increasing awareness of the pre-O&G specialty within foundation training and supporting our junior doctors and medical student members. BUSOG was established in 2012 and we focus on being an integral source of information and support for medical students, but this is the first time we've been looking to expand our reach to junior doctors. We have an array of speakers today. We're looking at the 3 broad options in O&G after foundation training. So this specific talk that you've all joined today, over the next hour, will focus on ST1 applications. We'll be working through the application process from 3 newly appointed ST1s who all did really well in the application process as well, and they'll be sharing their tips and pointers as well with us. Just a disclaimer, some of you may be aware that the new timetable and everything has been released for this year's round of ST1 applications, and it appears that there may well be some changes due to COVID-19 pandemic in terms of how they run interviews and how they approach weighting and scoring. So, where possible, our speakers will talk about this, but do bear in mind that they will be drawing broadly on their experiences from last year's round, all right? So there could be a few different changes this year. Just a few housekeeping rules. Please do keep yourself muted to minimize any disturbance during the event. We are hoping for a smooth running event, but if there are any technical difficulties, please bear with us. We will look to rectify the problem as soon as we can, all right? Any questions that you may have, just do try and save them to the end of the session. We're going to do a big Q&A right at the end. You hopefully should have seen a post online with all the Slido links. So we're going to be using Slido. You can connect with the event code and you can post any questions on there from now actually and take it from there. Okay. So with no further ado, why don't we hand over to our first speaker. So our first speaker is Dr. Nirmata Idnani. She's an ST1 in Obs and Gynae in Northwest London. She was a foundation trainee in the same deanery and completed an F2 rotation in O&G, which ended up being extended to a total of 8 months due to the COVID-19 pandemic. Her interests in Obs and Gynecology include fetal medicine and early pregnancy, which she developed when she completed a master's in research on the quality of life of women suffering from nausea and vomiting in pregnancy. In addition to her clinical duties, Nirmata is a trainee representative on the Royal Society of Medicine Obstetrics and Gynecology Council. So I'll now just hand over to Nirmata. Enjoy.
Thanks for the introduction, Shabini, and thanks, BUSOG, for having me here today. Just a bit about me. I was born and brought up in Hong Kong, and I moved to the UK for medical school. I did my medical training at Peninsula, so I was in Exeter for 2 years, Plymouth for 2 years, and then I took a year out to go up to Newcastle to complete the master's research program that Shabini mentioned. And then I went back to Torbay for final year before moving to London for my foundation training, and I've just started as ST1 at Northwick Park Hospital, and I'll be at Queen Charlotte's next year. So just a bit about dates. So I've got in the middle column the dates that have been published for this year, and I've put on the right just dates that were last year's dates, so you have an idea as to when we got the invitations for the MSRA and the interview, because those haven't been published yet. So on the recruitment page, they've said that applications will open on the 5th of November and close a couple of weeks later on the 1st of December. It's a 2-part application process. So you set the MSRA first, which I'll go into in a few minutes. And then you do the interviews after that. And when your preferencing options will open, or for us opened after you've sat the MSRA, but before the interview process. So the changes that they've so far highlighted for this year are that the highest scoring MSRA applicants will be offered a position without needing to interview. And the interviews will be held online this year using Microsoft Teams in the 2 weeks of March. Last year, in terms of scoring systems, we were scored out of a total 200 points, and a quarter of that came from the MSRA, and 3/4 of the score came from the interview process. And I assume they will keep that the same for those who are having to interview this year. So just a little bit about the Oriel application. So I've got on this slide the headings of the different application process. Just to comment that it was quite a straightforward application. So it was mainly just personal details, and we didn't have any white space questions or didn't have to score ourselves on our portfolio or a demonstration of commitment to specialty. So for instance, sorry, I've got my notes here. So in the personal details section, it's just your contact information, any special circumstances for you to remain in a particular deanery, and whether you'd like to defer your start date. In the eligibility section, we had to put in our GMC number, as well as whether we did our undergraduate degree in English. And for those who aren't, who are international medical graduates, there was a bit about right to work as well. In terms of fitness to practice, we had to say about any criminal records, fitness to practice proceedings previously. And then the next bit is probably the one that requires the most amount of work, so it's your references. We had to give 3 references of people who've supervised us in the last 3 years, and one of them had to be your current employer. So I used my supervisor, my clinical supervisor of the job that I was in at the time of applying. From your supervisors, you'll just need their name, their email, and their title. And they will get sent out an email to complete the references. Next part was about competences. So it was where you did your foundation training, as well as where you got your medical qualification from. And then they required an employment history for the last 3 years. So if you're applying straight from F2, you would include your undergraduate education as an employment gap prior to F1, F2. And the next part was evidence, but this was left blank for the Obs and Gynae application. We didn't have to submit any evidences. And the next part was any supporting information. So you had to declare whether you had previous experiences of more than 24 months, which precludes you from applying for specialty training, but it does not include any foundation training blocks. And they also asked if you were also applying for academic training, which you'll hear a bit more about later, and whether you had any special arrangements or adjustments for equality purposes, as well as you had to take a disclaimer that you knew that you had to sit the MSRA and you'd be happy to make your own arrangements to do that. And then there was the preferences section, which wasn't open at the time that we were applying, but got opened a bit later. And there was a bit on equality, which was for monitoring purposes, and was not going to be assessed. So it was an optional whether you completed that or not. And then finally with the declaration that you felt that you met the essential criteria in the personal specification. So I'll just start by talking a little bit about the multi-specialty recruitment assessment. It's got 2 parts to it. One is the professional dilemma section, which is similar to the situational judgment test. It lasts for 95 minutes and there are 50 questions, 8 of which are pilot questions for next time, so they don't count towards your total score. There's 2 types of questions in the professional dilemma section. One, similar to the situational judgment test, one was ranking the 5 answer options in the order. And the second was you had a multiple choice question where you had 8 options usually, and you picked the 3 most appropriate actions in relation to the scenario at hand. An important thing to think about that one is the way I did it was I read all 3 options out loud in my head to see whether all 3 actions would make sense together. So if the 3 of them didn't go nicely together or they contradicted each other, like those probably aren't the 3 right answers. The questions were 50% of ranking roughly and 50% of multiple choice. And they were based on three main domains: professional integrity, coping with pressure, empathy, and sensitivity. When answering these questions, it's really useful to assume the role of the F2, even if you've got more experience and you've done a few more years. Answer as though you would have done if you were F2 based on all the experience you had gained from F1, F2. And the second part of the MSRA is the clinical problem solving, which lasts 75 minutes and you've got 97 questions to answer, 11 of which are pilot. And again, 2 types of questions, roughly half-half. One is the extended matching questions and one is the single best answers. And it's essentially like your medical school finals and covers all the various clinical topics that I've listed there. So quick tips, there's no negative marking, so attempt all of the questions and be mindful of your time left over so you don't run out of time and don't answer a few questions. That's particularly important because if you spend 4 or 5 minutes doing one of the questions and it turns out to be a pilot question, you won't score anything for those questions and you would have missed out on the questions that were actually would give you points. So before I started, I just wrote down the start time and the end time, and I divided up my time. So for example, if the exam started at 11 and it was going to finish at 11:30 for the professional dilemma, I sort of wrote down by the 10:30 mark, I should have done this many questions. By the 11, I should have done this many questions, just to keep an eye on time so you don't run out of time. And I know people did run out of time, particularly in the professional dilemma section. It's just something to bear in mind. I recently added this slide because of the implications of the MSRA scoring, meaning that you may not have to interview. I also applied for GP training last year, and the GP recruitment process has been offering this for a few years now, where candidates don't interview and get an offer based on MSRA scores if they do well. The way they have done it is if you score more than 550 points, you automatically get an offer. And I don't know that that's what the OBS and Gynae recruitment are going to do, but just an idea that they might have a cutoff score. So I put my score there just to give you an idea of what the rankings and how much of a difference every point makes. So I scored 586, but I still only ranked 442 in the ranking for all the GP applicants. It was okay because I still got my first choice, so I don't think the rank matters so much, but every mark, so if you scored 587, you could have ranked 100, 200. So every point of a score matters. So that's particularly helpful for when you're doing your ranking questions, that getting it as close to the mark scheme gives you points that make a big difference to your ranking. And last year, the GP training program released scores as well as the percentages of how many applicants scored in each range. Again, so the scores in red are the scores that I got. And so you can see if you wanted to score above 550, for example, and wanted 275 in each, that's roughly top 15%. So if you've got 300 applicants for O&G, potentially 45 might get a place without needing to interview. So another top tip, especially people applying in London, the slots run out really quickly. So last year I got the email from GP recruitment before I got the email from OBS and Gynae recruitment. So I was able to book before my colleagues who had only applied for OBS and Gynae got to book. And that meant that I was able to get a slot in London, but quite a few people who lived in London weren't able to get London slots and had to travel outside. So just keep an eye out for the emails and book onto a slot as soon as you get the email as much as possible. And in terms of preparations, obviously when I was preparing for the MSRA, I spent as much time preparing for the MSRA as I did every single interview station because they were all 25%. But I probably would have spent a bit more time preparing, particularly for the clinical problem solving section, if I knew that it was a direct entry for OBS and Gynae. So just a few resources for how I prepared for the MSRA. There's a few really useful documents that you can read. I have the links to it, so if you're not able to find it off Google, feel free to email me and I can send them out. So you have the GP recruitment blueprint for the MSRA that just goes through the different question types, how they score you. And the Medical Protection Society have also released a document on the MSRA, which is useful. There were a few free webinars that I attended last year. There was one by the BMA, but I've checked and they haven't released one for this year. I don't know if they will still do one this year, but that's just something to check. eMedica is another organization that deal a lot with GP training. They've got, again, a free, They've got a free YouTube webinar. Again, I have the link to, or if you put in eMedica MSRA, you should be able to find it. A disclaimer for that one, that was done last year. So as much as it's useful to know about how to answer the questions, tips and tricks, they mentioned that the MSRA is 25% of the score because that's what it was last year. So that's not accurate for this year. You would get direct offers as you would do for GP training. And then finally, there's a BMJ module as well on the MSRA, which is useful to go through. In terms of the question bank, so I did all 3 of those question banks, but I probably found MCQ bank the most similar to what the questions were on the day. Past medicine was useful for having information about revision for the different topics, but the questions I found were quite different to the MSRA questions. And I also did the e-medical question bank. A bit about the MCQ bank, that's again targeted mainly to GP training. And I think GP training stage 3 is a communication skills station, as it is for obs and gynae. So MCQ Bank has this section where they recorded consultations between an actor and a doctor, a medical student. And at the end, they analysed the whole consultation and gave tips and tricks of how to respond to patients' questions and things. I have to say I ran out of time, so I didn't watch very many, but the ones that I did were helpful for the interview station as well. And then again, there is an e-medical course. I did not attend that because I'll talk about it, but I went to a few interview courses. So I felt that I didn't need to go to the course for the MSRA, but you can have a look on their website. They have a lot of different packages and options for the courses. And last year, MPS were offering some discounts. So if you are an MPS member, worth checking before you sign up to one if they do have any discounts. And then finally, I'd recommend the Pearson View tutorial that just takes you through the screen, the different options, and how to actually answer the questions on the day. And so now I'll talk a bit about the interview. So there are 3 stations in the interview. Ours were 10 minutes each. And I had a panel of 2 examiners per station, and this was held centralized in the Etihad Stadium in Manchester, but it's now online on MS Teams. I've put links for 2 courses, and I attended both of these courses, just in case you wanted to have a look at them. And these were the 2 books that I found the most useful. The book on the right is for general medical interviews, but I actually found it really helpful, particularly for the portfolio station, to get an idea of different question types and how to answer them. So the first interview station is your structured interview station. It's split up into 4 different sections mainly, the first one being your commitment to obs and gynae, the second one being your understanding of the career, the next one being your academic qualifications or skills, and then finally any personal qualities. So just a few examples of different questions. So for commitment to O&G, there were questions such as talk me through your CV, why O&G, how have you shown commitment to the specialty? In terms of understanding of the career, the questions were along the lines of what would your training priorities be in the first 12 months? What is the future of O&G? What sort of challenges do the trainees in O&G face? In terms of academics, so I've listed them there, but it will be what's your teaching experience? What's your research experience? Should everyone do research? What's the difference between an audit and a quality improvement project? Tell us about a recent research paper that you've read. And in terms of personal qualities, the person specification has a section titled personal qualities. So I would just go through that, make a list of the qualities that they want in their trainees, and then an example of how you fit. So the kind of questions were, tell us about a mistake you've made. How would you describe your communication skills? Give an example of a time you demonstrated empathy, an example of teamwork, an example of leadership. So I would say obviously time limits this, but try to prepare answers to as many questions as possible, because even if you don't get asked that exact question, you can manipulate the answer to fit the different questions. So an example in real life for my interview, I got asked about, give us an example of conflict, which is a really broad question and probably one that I would have struggled with on the spot. But I had prepared an answer to a question that was along the lines of, tell us about a time when you had to defend your beliefs about treatment for a patient. And I was able to use that same example and turn it around to answer the question about conflict. So time permitting, try and prepare answers to as many questions as you actually can. And then in terms of how to structure your answers for the different questions, there are 2 broad mnemonics. So the first one is CAMP, and that's useful for questions that are about commitment to specialty, just open general questions, and you can split your answers. So for example, for why O&G, you can split that into the clinical reasons, academic reasons, any management and any personal qualities that you feel you have that makes you suited to the specialty. And the second sort of question type would be like an example of teamwork, when you have to give examples of clinical scenarios, you could think about it, approach it in the STAR mnemonic. So that's describe the situation at hand very briefly, the task that you were asked to do, the action that you took, and then what the result was and what your reflection or your learning point from the example was. Try and keep your answers to 1.5 to 2 minutes, and that's because you need to talk for 1.5 minutes or so to give them enough detail to understand the context of your answer, but not to answer for too long, because they have to get through, the mark scheme requires them to get through all the different sections that I spoke about. So if you spend too long talking about one, you might not be able to answer a question on research and not score for that. I would recommend writing out your answers and then practicing them out loud. So I recorded myself and listened back so I could listen into my tone, the kind of words that I was using, how I was structuring my answers. And it's not very natural for us to talk about ourselves, purely because we've not had to do an interview in so long, that I would say actively writing your answers out and practicing using power words in your answers is really helpful. So if you Google power words for interview, you'll get a whole load of lists. I've put an example of one. So if you're asked a question about teamwork, those are the kind of different skills and qualities that you can try and include in your answers. So the next bit is just quickly about your personal specification, about the person's specification. There's a few sections, but the ones that I picked out are the ones that you can work on to build your CV to talk about. So the first one was clinical experiences that they say are either desirable or essential skills. So one of them is an aptitude for personal skills, and you can demonstrate that by attending courses such as the basic practical skills course that the RCOG runs. However, this will be covered by a study budget in ST1 onwards. So if you want to use your F2 study budget for a course that you can't do later on, I'd recommend the basic surgical skills course. And that just gives you a really good foundation in surgical skills and not tying that you're unlikely to receive later on. And then you can do the basic practical skills once you're ST1. The second bit is about having relevant experience in other specialties. So if you've done a medical specialty, that's really useful to tie into your answers, particularly with advancing maternal ages and medical comorbidities. They value people who've had medical experience previously. And then obviously, if you've done a surgical specialty, you can talk about any procedures that you performed, how you developed your manual dexterity in those jobs. In terms of the academics, again, I split that into research, teaching, and audit. In order to talk about research, you don't have to have taken a year out to do a whole research project on your own. There are many examples of how you can show research without having done a complete study on your own. So one example is there's an online course that's free, which is the clinical practice, and you have to have done that before you can recruit patients. So I had to do that before I recruited patients in my study on the MRes. Once you've done that, most units will have a research midwife. You can approach the research midwife to ask what studies are running and ask if you could help with recruiting patient. So even if you're not doing a study from start to finish, you have helped with the recruitment side of things. Secondly, with research, it's not just about doing the research, it's about implementing that into your clinical practice and everyday practice. So you can talk about how you've implemented evidence-based medicine in your day-to-day practice, an example of a research paper that you read that then helped you when you were looking after a patient. In terms of teaching, so get in touch with your university's O&G societies and tell them that you're keen to do some teaching for them, and you'll be able to organize your own local, especially now with us doing so much of our teaching on Zoom, it's easier to do a national teaching session. And I'd recommend, I don't know if these are still running, but back when we were having face-to-face courses, I would have recommended the Teach the Teacher course. And that's, you can pay to do them, but there are a lot of free ones available. So have a look online before you go and pay for one. I did mine free, and your hospitals sometimes also run them, so you can speak with your education centre to find out. And tie that into your answer. So for example, you can say, I did a teaching session on XYZ. The feedback I got was the session wasn't long enough. I went on this course, I spoke to the other people there, I spoke to the facilitators, got a few tips of always having 2 or 3 extra slides at the end of the presentation that I will go into if I've run short. I then used these tips in my next teaching session, and I got feedback that said it was the perfect length. So tie it into how you turned your negative feedback into positive feedback. And then finally, in terms of audit, so all of us have done audits. It's compulsory, you have to do one to pass F2, or you did before COVID anyway. The trickier part is completing the audit cycle. So make sure you know the audit cycle really well and try and complete the cycle. It's hard because of our rotations and we're not in the department any longer to complete the cycle. But if you haven't done that already, talk about your plans to complete the cycle. So the next station is your clinical prioritization station. These are deliberately non-O&G clinical scenarios. They give you an unrealistic scenario where you are the SHO covering the whole hospital, medicine, surgery, obs and gynae, peds. And there's usually 4 or 5 scenarios. You would be able to highlight quite easily, there's 1 really sick patient, 2 slightly sick patients, 1 patient who's difficult for whatever reason, and then 1 is usually a telephone consultation of a journalist wanting an update on a famous person in the hospital, or a patient's family member who wants an update, who happens to be a consultant. So it's how you would sensitively deal with those situations, even if you prioritize them as the last patient that you would go see. The brief also informs you who else you have on with you. So it'll usually say you have F1 and you've got a medical registrar, surgical registrar, and you're a consultant. So the common topics that would come up for this clinical scenarios that I went over before the interview were hyperemesis, acute limb ischemia, compartment syndrome, transfusion-related reactions, as well as upper GI bleeds. So usually one of the clinical scenarios is a patient who's septic. Even though they're really sick, you could actually think about sending the F1 to see that patient, because F1s are good at completing the sepsis 6. But whatever you delegate to the F1, always make sure you say, I would tell my F1 to come back to me once they've done that, or contact me if they need any more support. Or I would tell my F1 to look out for XYZ in this patient. So if it is sepsis, I would tell my F1 to complete the sepsis 6, which includes, and then list all of that. So just about being supportive if you're going to send someone more junior to you to see a patient. So in terms of structuring your answer, so at the start, when I answered this station myself, I asked for all of the patient's observations and the pregnancy test, because that might not be in your brief. And if you get that at the very beginning before you start answering, you can prioritize easily. People do this differently. Some will talk about all of them in the order that they're on the sheet and then prioritize at the end. I prioritized at the beginning and then started talking about them in the order of how sick they were. And I did it that way because you get more points, because you have more to talk about for the patient who's the most sick. And I just didn't want to inadvertently leave that to the end and then run out of time. So as I said earlier, delegate where appropriate to F1. There might be a patient who's in A&E, and if they're not the most sick patient and you can't get to them as soon as possible, you could say, I would see if there is an A&E doctor around who's able to help me with cannula and bloods, or ask the A&E nurse in charge if they could do that for me. And then essentially you go through every patient using A to E and talk about that. So in this station, the examiner might ask you, oh, what else would you do for this? What else would you do? What else would you do? They're not trying to trick you. They're just trying to help you, because the points are very specific to the words that you use. So you have to say, you get points for listing each of the sepsis 6. So if you've said sepsis 6 and not listed it, they might prompt you. So don't be put off. They are just trying to get you more marks that they can score you for. And the next station is your communication skills station. So it's usually with an actor. I don't know how they're going to run that if the interviews are all online this year, but they may do it as a video consultation, because I see that it seems that we're going to be moving on towards video consultations. They might want to see your abilities to do that. But it was a 2-part station, and you only get the brief for part 1 initially. And part 1 is focused on you building a relationship and taking a history from the patient. And as much as it's a history taking station, really focus on building a relationship with the patient, because part 2 almost always is dealing with a mistake that you've made or having to then break bad news. So the better the relationship that you have with your patient in the first part, the easier it'll be for you to then break the bad news or apologize to them for a mistake that you've made. And treat it as real life as you could. So react to the actor like you would a patient. So if the patient is saying, I've got pain, offer them analgesia at that point. Or if they're saying, I can't breathe, offer to put on some oxygen. And then the common topics that I looked up before the interview were counseling a patient on how to take warfarin, counselling them on or consenting them for a blood transfusion. And then the final one that came up quite a few times in the last few years is the consequences of having chlamydia, which then may lead to PID and questions surrounding infertility. So tips for that. So when you're speaking to the patient, when you've done the history takings bit of the scenario, when you're talking about your management plan, part of that will include the investigations. Now, when you tell a patient, I'm going to do bloods on you, you might not necessarily tell them, I'm going to check your full blood count and I'm going to check for infection markers, and they're called CRP, but go into that detail while you're speaking to the patient so that the examiner can listen in and give you points exactly for which bloods you would do, or which imaging modality you would adopt. So another mnemonic to use for the communication skills station is SPIES, and that stands for seeking information from the patient, so the history taking. Always maintaining patient safety as your top priority. So by that, I mean, if the patients come in angry, complaining about something that happened a month or two ago, like they got lost to follow up or anything, start by asking, how are you? So quickly run through the questions to make sure that they're stable and safe now before you delve into the complaint. And show initiative. So if it's something that you've made a mistake about, so prescribing the wrong blood, well, no, you wouldn't. So administering the wrong blood type. When you're talking to the patient, you wouldn't necessarily tell the patient, thank you so much for your feedback, I really appreciate that, I'm going to reflect about this in my portfolio, but say those kind of things because the examiner is listening into what you would do. And always escalate if it's something that's gone wrong. So if you are only the F2 or the SHO, so offer an appointment with the consultant so they can talk about it further, and mention that you would, and mention PALS to them should they wish to make a more formal complaint. And if there is a situation for which you need to put in a day text, do that. If it was a drug allergy, if they were having a drug reaction, so now they have a drug allergy to a drug, say that you would then give them a red wristband. So just think about all the different things that you could do in real life and talk through that with the patient. And then finally, so support. So offer for them to bring in a relative, offer to speak to the relative on their behalf, write information down, and actually, or like providing them with support leaflets. They might intentionally ask you tricky questions like, will I be okay, doctor? So try to have what's comfortable for you as an answer to those kind of questions. So there's just a few things that I read before I had my interview and just suggested for you guys. So just look through the structure of the training program. So ST1, ST2, you're an SHO, you need to do your part 1 MSRA before you can progress to being a junior registrar when you're first on call on labour ward, so ST3 to ST5. And then you become a senior registrar when you're ST6 and 7, and when you have to pass your part 2 and your part 3 MSRA. I also looked up the ST1 and ST2 competencies. It's recently changed. I think it was last year that they changed it. So the only competency for ST1 is cervical smears. So you can say, I'm going to work on getting that signed off early, and then I'm going to start building towards my ST2 competencies, which include things like doing a basic cesarean section, etc. So knowing all of that, you can tie that into your answers in the portfolio station. Have a read of the Embrace report. Have a read of the Embrace report to understand what the main reasons for maternal morbidity and mortality are, so you can talk about how you'd focus on those. I also read the RCOG workforce report because the college are looking into how they're going to prevent all the sort of difficulties that the specialty is facing, for example, burnout. And then finally, I prepared one clinical research paper in case I ran out of things to talk about in the research, and I did. They asked me my research experience. I talked about my whole year of masters in research, and they still asked me, what other research experience do you have? Which obviously threw me off at the time because I was like, I did a whole year of a master's in research. But it meant that I could talk a bit more and pick something that's clinical or that's of interest to you. So for example, the one that I prepared is the anode study, which I'll talk about really briefly. So essentially, I was on labour ward one day. We did an instrumental delivery, and then the registrar asked for a dose of antibiotics to be given to the patient, and the midwife said, we don't do that, they don't need it. And actually this study was relatively new at the time that said that it makes a difference to infection rates if you did administer antibiotics. So it was something that was relevant. I could tie it into my everyday practice and explain how I implemented it in my practice, because then I was the one prescribing the antibiotics. So that's everything for me. Happy to take questions later in the Q&A, but that's my email address as well. I'm more than happy for you to email me if you have any other questions or wanted any other advice.
Great, thank you, Nomata, for that. That was such an informative presentation. I'm sure a lot of us will agree that that's really run us through the application process. So what we're going to do next is we're going to move on to our next speaker. Give me a second. So our next speaker is Nayati. We have a familiar face, Dr. Nayati Sadani. Some of you may recognise her from her role on the National BUSOG Committee from last year. She's recently started her obstetrics and gynecology training in the Wessex Deanery this year. She studied at St George's Hospital and Medical School, and then subsequently completed her foundation training in the Peninsula Deanery, which included a rotation in obstetrics and gynecology. Nayati's interests include fetal medicine and fertility. At medical school and during F1, she held roles as the events coordinator and ambassador for BUSOG. She helped organise successful events such as Unheard Voices in Obstetrics and Gynecology back in June, and the Pregnancy Loss Symposium, which is due to be presented orally at the next RCOG World Congress. So I'll hand over to you, Nayati.
Hi everyone, thank you so much, Shabini, for having me here today, and I really hope you guys find my talk useful. Can you see my presentation?
Yes, we can.
Okay, great. So thank you, Namata, for telling us about the application process. That was very informative, and essentially what I want to do is tell you a bit about my personal insights and experience and how I found the application process. So starting with my background, I went to St George's Hospital Medical School, and that was where I first did my 5 weeks of obs and gynae and was then interested in this specialty. I did 2 weeks of obs and gynae in New York as part of an SSC program. I then did my F1 and F2 in Peninsula, did my F1 at Derriford Hospital in Plymouth, where I did a taster week in O&G, and then did a 4-month rotation in my F2 year in Torbay. And that third picture was the view from my flat in Torbay, which was very nice. I was also part of BUSOG as both ambassador and events coordinator for the last few years. And finally, I'm now doing my obs and gynae training in Wessex. I started an ST1 in Poole Hospital just a week ago. And that last picture is the view from the early pregnancy unit in Poole Hospital. So I just thought I'd show you a bit about what a typical week as an O&G ST1 is. So this is my week commencing next week, which is when I'm on normal days. So it's really varied. You're on section lists, you're doing postnates, you're also doing gynae on calls, you're on antenates, you're getting to do lots of surgery, both gynecological and obstetrics. So as you can see, it's great because you get to learn a lot and do a lot as well. A bit about why I went straight into ST1 after F2. It was an easy decision for me because I knew what I wanted to do since sort of 4th year of medical school. And I thought, if I know what I want to do, I'm ready to get stuck in. You have more opportunities earlier on in your career. So if I want to take an out of program experience sort of after ST2 or ST3, then I would have done quite a few cesarean sections, would have done instrumental delivery. So if I wanted to go abroad and do some work, I have more to offer because I've had a few years of training. You're well looked after in a training program. You've got a clinical and educational supervisor. And I guess it's nice to feel like you've settled in and you're guaranteed a job and pathway. I guess some of the cons of going straight into ST1 after F2 is you miss out on other opportunities that you could do between your F2 year and ST1, such as research. you know, I look at my friends who are locuming and have a bit more flexibility to do other things and probably earning a lot more than I am and working less time. And I did have this slight feeling last week when I started, when I was sort of a bit younger than everyone else, and I felt less experienced because people had done more O&G experience in sort of the year that they took out. But the one thing I have realized in the last week is that when you're an ST1, they're happy to teach you everything. Doesn't matter to them how much you've done before, because they will teach you everything that you need. So Namata's talked a lot about the application process. I won't go too much into it. The only difference this year, as Namata already mentioned, is that if you do really well in the MSRA, you won't have to do an interview. Again, Namata went over sort of studying for the MSRA quite well. She used similar question banks to what I used. The only thing I'd like to add is I downloaded the Pass Test app, which I found quite useful, because when you're really busy sort of doing your F2 job or doing something else, you've got the app ready to go. So in your lunch breaks, or if you're commuting, you know, you can use the app, and I sort of felt like I got a lot of revision done that way. So these are some of the interview resources that I used. I went to the OG, the first link is for a course that I attended last year in London. It was a course I was only taking 6 people at a time for a day course, where they go through all the interview stations and you have a mock interview at the end of it, which I found really useful because it was more one-on-one feedback. I have looked on their website, and I don't know if they're running it this year or if they're running it virtually, but it might be worth emailing them using the email on the website to see what they're doing this year. I also used MediBuddy, which was really useful because they had sort of all the questions that have come up in the last few years, and they also got the years next to the questions, you know, when exactly they came up. They've also got suggested answers, which could help you prepare better as well. The third link, obsandgynae.net, again, that's another course that I didn't actually attend, but I paid for their course material, which is valid for a year. It was really helpful because they had excellent presentations on all 3 stations, and they had mock interviews mock stations, about 7 scenarios for each interview station, which was great because you can practice that with your family or friends. I think my main advice for the interview is practice, practice, practice. If it's going to be online this year, make sure you've practiced with family or friend doing it virtually, because it's quite different from doing it in person, and just being able to make that first impression online is a lot harder. I also used the 2 books that I've got pictures of on the slide. Again, they were both really useful for preparing for the interview. So the first interview station is the structured interview station. It felt like a rapid fire round because they've got all these questions to go through, and they will interrupt you if your answer's too long, which initially I thought I'd get put off by, but if you go in being aware that they're going to do that, you just sort of try and get in as much as you can in the minute and a half, and sort of putting your answers to that time. And the way the feedback was given, they sort of measured it through these 5 different components: commitment to specialty, quality improvement measures, research and teaching, experience out of O&G, and the global score for communication. So in terms of commitment to the specialty, again, use your personal experience. It's okay if you haven't done an F2 in O&G, but if you've done anything like an elective, an SSC, taste a week, or if you have done a foundation year rotation, the one piece of advice that I got told at the beginning of my F2 rotation was write down all the useful experiences or examples that you have as you go through the rotation, because when it comes to preparing for the interview, you can then look back and you don't have to try and remember those examples because you've written them down as you've gone through. So I found that quite useful. Namata's mentioned some of the courses. Again, the basic practical skills in obs and gynae, that's something you can do as ST1, but if you'd like to get ahead and do it as FT2, especially my foundation school were really good. They gave me funding to go attend it, which was really useful. There's also the prompt course. So they ran a prompt update day as part of our F2 rotation when I was in obs and gynae. So that was quite useful, and they gave us access to some CTG training as well. Again, you'll do all of this at ST1, but if you've done some of it beforehand, it shows commitment to specialty. Moving on to the MRCOG Part 1, it's not a necessity to do the MRCOG Part 1 before you start ST1 training, because you still have to complete it by ST2. But again, if you have a rotation in F2 where you feel like you have time to do it, or you're taking a year out and have time to do it, I'd highly recommend doing it, because again, they do find that impressive in the interview as well. If you've been part of an Obs and Gynae society in medical school, it would definitely be worth mentioning that. And again, as Namata said, make sure you understand the training matrix and look at the curriculum and if there have been changes to it recently. And they do tend to often ask about the challenges faced as an O&G doctor, so make sure you're aware of those, but also to tell them what the challenges are and maybe put a positive spin on it. Quality improvement measures. So we've all done audits and QIPs. It's just making sure that you know the project really well and what you've learned from the project. And if it was presented at a conference, whether it was local, regional, or nationally, it's worth mentioning that. So research and teaching. So if you've got a research project, that's really good. Just make sure you know it really well. So when they do ask you about it, you can tell them about it in a concise manner. It's okay if you don't have any research project or haven't had a year out of research, because that was something I was quite worried about because I hadn't had that. But if you've done any case reports, it's worth mentioning that. But also the other things you can talk about, if you've done the GCP online training course, if you've attended journal club and presented at journal club, again, that counts as research. So that is, if you don't have a massive research project, you can use, you know, your experience in journal club and evidence where you've used evidence-based medicine. Moving on to teaching, they did ask me what the qualities of a good teacher were. So again, you could list those qualities, but incorporate how you possess those qualities using your examples. Have examples for a range of teaching. So if you've done one-on-one bedside teaching or departmental teaching or sort of informal teaching, just have those experiences. And if you've received feedback on those on that teaching, then make sure you talk about that and how you've improved it for future teaching sessions. So experience out of Obs and Gynae, team working and leadership. Again, you can use examples within work and examples outside work. So at work, you'd have examples of teamwork on the ward. You'd have leadership where you've led an audit, equipped, or, you know, organize a teaching program yourself. You can use examples of, you know, what people have said from your tab, in F1 and F2, but again, make sure you qualify those what people have said about you with examples. You can also use examples out of work. So again, if you've been part of a university society, that's something that, you know, if you've created a society or something, that's definitely worth mentioning. Playing sports, if you've been captain or president of a club, again, that's really good. That it shows that you have interests outside of work as well. And if you've organised an event, that's something to mention as well. And then the last component of the structured interview is your global communication score. My main advice is you've only got 15 minutes, so make sure you're smiling throughout, that you're very passionate, that you're passionate and enthusiastic. Practice your answers, that you can speak quickly and fluently, but keep it concise as well. You don't have very much time, unfortunately, to get across all your points. So you do need to practice and be prepared for the interview. Moving on to the clinical station, I think Namata did talk about this in detail, so I won't say too much about it. Essentially, your surgical SHO with 4 to 5 scenarios. My main advice for this station is practice the scenario. So I don't know about everyone else, but I'm quite used to using a pencil to note things down when I'm trying to work out a problem or, you know, go through a clinical scenario. But so for me, it was particularly difficult that I had to work through these scenarios without using a pencil. So that's something I practiced quite a few times, and also practicing talking at someone for, you know, 10 to 15 minutes. They do sometimes prompt you to say, what else would you like to say? But actually most of the time you're going through those scenarios and it's just you talking at the interviewers. So again, I think it's quite an important station to practice, because you need to get used to that awkward silence that you'll have from the other end. Common scenarios that they bring up in the clinical station are the ones mentioned on the slide. Just remember your A, B, C, D, E. There's always usually a fourth or fifth scenario which has got to do with a patient's relative calling up the ward and asking for some information on the patient. So for some golden points, it's good to just go over the GMC confidentiality rules so that you know you can sort of quote them when you're giving your answer to what you would do for the last scenario. So the communication station, in my opinion, is the most difficult station and easiest to fail, because I think it's very much establishing that relationship with the patient and to make sure that you pretend that it's real. Again, a lot of this Nimata mentioned, but I think it's just making sure that you build that rapport with the patient quite early on. So just a bit about choosing your deanery. For most people, it's quite a personal decision, and the location might depend on where family are, where your partner is, and you might pick your top deanery based on that. The other thing to bear in mind is that you are going to be moving around for 7 years. So for me personally, Wessex was a good deanery because I could sort of live in one central point and actually commute to all hospitals within an hour. I personally chose Wessex as well because I love living by the sea, and it was quite reassuring that it had been ranked #1 for satisfaction for trainees in 2019, and I'd heard a lot of good things from trainees within the deanery as well. Last year you could rank most deaneries allowed you to rank ST1, ST2 locations within the deaneries. So you could pick where you want to be for ST1 and 2 within sort of a deanery as well, and rank those, so at least you know where you're going to be for the next 2 years. This is just something I was a little bit confused about, so I thought I'd just go over the offer process in short. So when the offers are released, you have 3 options. You can accept the offer. If, let's say, you've got your third choice instead of your first, you can accept the offer and choose to opt in to automatic upgrades. So what that means is you've accepted the offer, but if the 2 above that were then to become available, you would automatically be upgraded to a choice above the third one. The second option is holding the offer. So if you're unsure whether you want to take that offer, you can hold it till the deadline, which this year is the 16th of April. So you're giving yourself more time to make that decision. But you can choose, again, with the hold offer, you can hold it, but you can choose automatic upgrades where you're upgraded to a choice above yours if you don't get your first choice. So you have, if you get upgraded later on, you can accept the offer after, if that's what you were waiting for. And if you don't want the offer, you decline it, and this offer is then recycled and offered to another applicant. Just to bear in mind, if you do choose to opt in for the upgrades, you can re-rank the preferences. So if you got your 20th choice out of sort of 150, you can re-rank the 19 choices above it if you changed your mind about where you want to be. Just a few things to remember. You don't need lots of O&G experience. You just need to be passionate about O&G, show that you've got commitment to the specialty by other things that you've done. And, you know, it could be whether it's experience within medicine, within surgery, and how you're going to use those skills to be a good trainable candidate. And, you know, the deanery will train you and equip you with the skills you need. Start building your portfolio early. This year, I guess, you know, some people might not have an interview if you do really well in the MSRA, but if you do have an interview, practice for it, bring out everything you want to say with examples. And I'd also advise sorting out your references before the application process, because sometimes it can be quite difficult to contact people when you sort of need to put that email address within the time period on Oriel. Well, thank you so much for listening to my talk. We'll have a Q&A session at the end, but if you have any questions, that's my email address, and I can always send you some of the links I've mentioned in my talk.
Thank you, Nayati. Yeah, thank you for a really informative talk. You've really touched on a few things there. In the interest of time, I'm just going to move on very quickly to our next presenter, Dr. Syra Danji. So she's a current ST1 trainee in obstetrics and gynecology in the North West London Deanery. She's doing her ST1 at Northwick Park Hospital, followed by an ST2 at Queen Charlotte's Hospital. She graduated from King's College London in 2018, where she completed an integrated BSc in Healthcare and Management. She then went on to do her foundation training in Oxford and is particularly interested in fertility and assisted reproduction. So I'll quickly hand over to Syra.
Oh, can you hear me now?
Yeah, we can hear you well, Syra.
Share my screen. Just let me know if you can see it.
Yeah, working well.
Wonderful, perfect. So hi everyone, my name's Syra. Thank you for inviting me to speak today, Shobhini, and the whole team for organising the event. I know Namata and Nayati have spoken in depth about the application process, so I won't dwell on anything too much, but hopefully I can add just some top tips that I found useful in some of my experiences from the application process. So just a little bit about me. As Shobhini said, I went to King's College and then I did my F1 at Stoke Mandeville Hospital and went on to Oxford to do my F2 in the John Radcliffe Hospital, where my first rotation was 4 months in O&G, which was really useful. I'm now at Northwick Park and I'm off to Queen Charlotte's next year, so the same as Namata. So just touching on the MSRA, things that I found really useful for preparing for the clinical side was my medical school final notes. So it's very similar to your finals, maybe slightly less in depth was my personal view. This is just the blueprint from the MSRA blueprint and information, and it just goes over the main topics that you'll find. Women's health tends to come up a fair amount, so I would revise that. And also I would say GP topics. I was quite fortunate that when I took the MSRA, I was on my GP block and I found knowing things like the antibiotics for tonsillitis and all of the different infections, otitis media, is really, really useful. So definitely go over that. On the Blueprint website, you can also find sample questions, which is really useful to go over just so you know the actual format of everything. And I also used Past Medicine. I went through the question bank twice, and that was the only question bank I used, and I scored pretty highly in that section, higher in clinical than on the professional dilemma section. So that would be my advice for that. In terms of professional dilemma, there's 50 scenarios. I found some of the scenarios slightly more abstract than the SJT that we had at the end of med school. So I would definitely go through the GMC ethical guidance. It's about a pack of about 10 books. I don't think they're sending it out at the moment because of COVID, but at the end of my presentation, I have the link for them. Just have a very quick flick through. You don't need to dwell on anything for too long, but it just highlights the main points that you can implement when looking at the questions and when ranking things. Past Medicine was also very useful. Like Namata said, the format is slightly different, but the concept is the same. So you practice the ranking, you practice the picking of 3 in unison. So the 3 things have to work well together. So I would say definitely practice those on Past Medicine because you can get into the habit of just checking with yourself whether that's the case. Again, do the sample questions, and I actually redid the SJT practice papers for foundation application, and I did both of them twice because I found those explanations particularly useful in just the way you approach the questions and how to answer them. So I want to focus a bit more on interview prep. I don't think there's anything that can replace practicing and practicing with others. You might not necessarily have a friend or a colleague who's applying for O&G this year, but if you practice with any other medic or a family member just out loud, it will help you so much because you'll be able to phrase your answers in the way you want to. It'll help you practice your timing and just help you speak confidently, if anything else. The book that I found most useful was this pink book in the middle. It's a book that was written by an ST1 applicant in 2015. So she's a current trainee in London, and it goes through every single section of the interview with lots of examples and practice mark schemes. So that's incredibly useful. as Namata said, this black book on the end is also very useful, because often you have questions which are a bit more general, like what is clinical governance, what's the difference between audit and research, and I think that book really goes over everything very well. So certainly get those two. So for your structured interview, this is the station that I personally found the most daunting, because I'm not really one to talk about myself for sort of 10 minutes, and there is a lot to fit in. 10 minutes to me sounded like a really long time, but it flew by. I couldn't remember half of the things that I said in the interview because there's so much adrenaline running through you, but this is why practicing and preparing answers is so important. So for example, why O&G? I personally think that's the most important question to prepare. It will be the first question they ask you, and that's the impression that they will have when you walk out the door. So be passionate when you answer that question, smile when you answer that question, tell them exactly why you want to do O&G. Go over the training matrix, know when the critical points are. So for example, ST2 to ST3 when you act up as a reg, and then between ST5 and ST6 when you become a senior reg. Those are important points to know. They'll probably ask you what your priorities are in the first 12 months of training. So like Namata said, what you need to get signed off is cervical smear, but then you want to work towards, for example, being able to do a perineal repair. There was a new curriculum in 2019 and they're quite hot on that. So have a quick look on the RCOG website about what's included in that and how it's less of a tick box exercise now. And we're trying to be a lot more patient-centered. So just have a quick look at that. Think about the challenges facing trainees, because all of the consultants and registrars there recognise that it's a really difficult training process, and they'll want you to recognise that before going into it and think of the ways that you can overcome that as well. Things that can show your commitment, like Nayati said, prompt is very, very good. So that's the practical skills, and it's a multidisciplinary day event. If you happen to be on O&G or have it later on this year, even if they're not including F2s in that, just ask a consultant whether you can hop on to that session, even if it's just half a day, just to get a flavour of it. Basic practical skills is also very useful. Unfortunately, I didn't have the opportunity to do that before I had applied, and they asked me whether I had done that in my interview, and I had to be honest and say no, but it's also absolutely fine to say no, as long as you are honest. If you have an opportunity to present at any M&Ms, whether it's O&G related or not, that's very useful because it's something that comes up a lot in obs and gynae. And again, any taster weeks you've done, whether it was in a tertiary hospital or a DGH, is also very useful. So in terms of the quality improvement measures, certainly know what quality improvement is. Practice talking about one of your audits. Just pick one and practice summarising it in 1.5 to 2 minutes. It does not need to be O&G related. I discussed one that I did in my orthopaedics rotation, and they seem to find it very interesting, as long as you say that you have or you plan to close the loop and that you understand why audit is important in our practice. Keep it very brief and tell them whether you presented it or not. You have a bit of time before your interviews if you end up doing an interview, because some of you may not if you score well enough on your MSRA. But you have time to present it before then, and then know, did you present it locally, did you present it nationally, or did you present it internationally? You might have a little bit more opportunity to do a national presentation now that things are on Zoom, so certainly do try to do that. Research and teaching is the next section. This is something that I felt that I was lacking in, because I decided that I wanted to do O&G quite late. So I certainly hadn't done any research in obs and gynae. So for that, just discuss what sort of research you did. I discussed what I did in my healthcare management BSc, which is completely unrelated. But I said that I use secondary data, so I understand research, I know how to do a literature search. Whether you've critically appraised papers and talked about it in a journal club, all of that will tick the boxes that they want. They also asked me a question, which was, should everybody do research? To which I answered no, and a lot of my friends were very surprised that this is what I said. But I think the point is that as long as you can back it up with an answer that is logical and that resonates within you, they'll appreciate that. So it's okay if you don't tell them what you think they want to hear, as long as it's a genuine answer. Teaching, so what sort of teaching did you do? Did you organise it, or did you hop onto another project, which is also absolutely fine? Refer to feedback and try and bring up feedback before they mention it, if possible. And say both your positive and perhaps more constructive feedback and what you would do next time. And was it formal written feedback? If not, you may have time before your interview to try and get some formal written feedback, just so that you can say yes to that answer. We're very lucky that we don't have physical portfolios, but as long as you've done the things, you will get a tick in that box. Experiences outside O&G, leadership and teamwork. They want to see that you have interest other than O&G. Having gone to our induction for our ST1, again, everybody is very aware that it's quite a challenging pathway. So they want to see that you will be able to manage the stress of work, and you'll be able to switch off when you go home, and that you have other hobbies, interests, and things like that. The black book at the beginning that I showed you was incredibly useful for how to structure your answers for leadership and team working, and always think of an example. So 1 or 2 examples for each point will certainly make them remember you slightly more. And then you get a global score for communication that will be marked by both examiners. So the things that I would definitely suggest is smile. They will remember you if you are smiley, if you're passionate, and if you're just very, very enthusiastic, but as long as it's genuine. Try and be as concise as possible, because 10 minutes isn't that long a time, and they want you to fill in take as many points as possible, as do you. So prioritize your answers. When you're preparing, think, what do I want to get across first? Because they may stop you, and that's okay. Don't be put off if they've stopped. It's most likely because you've ticked that box and you've got that point, so they want to give you an opportunity to get the rest of the points. But try and prioritize your answers and sell yourself. I think we all find it difficult to sort of sit there for 10 minutes just talking about yourself, but it is your opportunity to show your best characteristics and show why you're suited to have that spot. So try to sell yourself and practice doing so. So next station is clinical prioritization. So these are some of the examples as discussed previously. Some of my top tips would be to always identify the most unwell patient first, and use language that will make them recognize that you have done so. So for example, unstable. So patient 1 is the most unstable, therefore I will attend to them first. Escalate when appropriate. So particularly for the unwell patient, you want to escalate. They'll always say that you have sort of a registrar and an F1. So use these people. Delegate appropriately and utilize the members in your team. So for example, if you have an FY1 and there's a cannula that needs to be done, you can say, I would send my F1. Observations tend to be given for most of your patients, but if not, you can ask for them, and always say that you'll approach things in an A to E approach. When you get there, is there any other information that you want? If you had a patient with an upper GI bleed, you could say, I would ask the nurse what the estimated blood loss is, so that they recognise what you're thinking about. And just talk through the process out loud. So what you would do, you're all sort of F2s or have done F2, so you know what to do. It's just about talking that through in a logical way. Be calm and be logical, because that's the characteristic that you'll need in obstetrics in particular. So if you can show that there, it will do you a favour. And give differential diagnoses. They want to see that that you're not just thinking about one thing, you're thinking about more than that. So for example, a piece of feedback that I got was when I had a confused patient, that I didn't think of enough things. I think I didn't think of enough reasons for a low GCS. So try to give more than one differential diagnosis, even if you know that that's not the case. And practice out loud. Phrasing is very, very important in these sort of scenarios, because there is quite a lot to get through in the time. But if you can say things in a concise manner, and if you know what keywords to use, sepsis 6, A to E approach, you'll find it a lot easier on the day. For the communication station, here are some examples. So first, I would take a structured and focused history, focusing on sort of the OBS and gynae symptoms. Systemic symptoms as well, so fever, weight loss, just to make sure that you don't miss anything. ask what observations you want, but act, you always want to stay in character. So if you want an observation, you can say, I'm just going to pop a cuff on your arm so that we can find out your blood pressure. What examination do you want? So do you want to do an abdominal examination? So say that to the patient, ask for permission, and then the examiners will know that that's what you want to do. Are there any investigations that you want to do? Do you want to do an ultrasound? Do you want to do bloods? Be very specific about the bloods that you want to do. So for example, if you want blood cultures, say that I'm going to take some bloods, including a blood culture, just to look for any bugs in your blood and things like that. Again, give differential diagnoses and then say what your management would be. So if you're going to admit the patient, just say to them that this will be our plan and we'll admit you. And the second part of that is the counselling section, or dealing with an angry patient. I was slightly thrown off because you only get the first part of the brief when you go in, and the second part of my brief, although it was related, was to do with something that I had already dealt with. So it took me a second to get back into character, and that's okay. So just know that it might be slightly unrelated, but that's okay. Top tips, open questions. I'm sure you're all very good at that. Always check for understanding, particularly when you're doing the counselling section. Give a wide list of differentials. Always reassure the patient and take responsibility. I think that's one of the most important points. If you're dealing with an angry patient, apologise, offer pals, offer follow-up, and just pretend it is real life. So, for example, with the cuff on the arm or admitting a patient. Try to always stay in character. I know it's probably very difficult when you have examiners there. I don't know the format that it will be in this year if it's online, but practice that online with friends and colleagues because it can be off-putting. So pretend it is real life. You will do this every day. And just some recommended reading. The Embrace UK Saving Lives report investigates into maternal deaths, stillbirths and infant deaths. That's really useful. And if you can sort of slip that in and cite it somewhere in a natural way, I think that would be very useful. And that's something that I did. Each Baby Counts. So that's an RCOG national sort of quality improvement project to reduce the mortality and morbidity of babies after labour. So read that. There's a summary document that I've got the link for, and that's also very useful. The GMC ethical guidance, which helps for the MSRA, and the MSRA blueprint are all good resources. And here are just some links that hopefully we can distribute or pop it on, maybe Shobini can pop it on the Facebook page, but they're all very useful, and I'm sure you'll all do amazingly, and good luck. I think I'll pass it back to Shobini, but we might be doing question and answers now.
Yeah, thank you, Sarah. Thanks so much for that presentation. And yeah, we'll look to post those links in the next, as we finish all the talks, and we'll make that available as well. So we're running a little bit over time, but I know that a lot of you have posted in questions. So what I'm going to do is I'm just going to have Nayati and Nimata join us back, if they can turn on their videos as well. And I'm just going to have a look at our Slido link. We've had quite a few rolling in. We've had lots of questions, so I'm just going to go straight into them with the ones that have been most popular. So the first one that most people have wanted to ask, what experience would you advise a foundation doctor needs to maximise their chance of attaining an ST1 and O&G post? So I imagine that means if those that haven't managed to get an obs and gynae rotation, what other things can they do?
Sorry, I was just trying to unmute myself.
That's all right, I just unmuted you. Go ahead.
So I think one thing that would be incredibly useful is taster weeks, because then you are sort of getting the same experience and you're not doing the admin parts of the job. So it's quite condensed in a week, but it will give you a flavour of what the job's like. It will make them recognise that you know the challenges of the job. So I think that's incredibly useful and something that I personally found very useful.
Okay. Another question we've had coming through, how much time did you allocate to studying for the MSRA/interview?
I probably started now-ish, October, And I spent a lot of time preparing, especially for the interviews, and wrote out answers to I think 70 questions, something ridiculous. I don't think you need to do that much. I don't know what the two of you did or how much time you guys spent.
Yeah, I think I'd say I sort of started nowish as well. And as I was saying, like downloading an app on your phone or being able to do some of the question banks on your phone was quite helpful as well, because it meant between going to work and then your lunch breaks and things, you'd be able to sort of do more practice, because it's quite difficult when you're an F2 and trying to juggle work with preparing as well.
Okay, great, thank you. Another question we've had, how competitive is ST1 for O&G? And if a place is not secured in the first time round, can you apply again? So I guess they're getting at, will you be at a disadvantage if you've applied and not got in the first time?
No, my understanding is that you're not at any disadvantage. So if you don't get in the first time, you can always apply the second time. So something that I didn't mention is that when I applied, I actually wanted to take an F3 and I wasn't 100% sure whether I wanted to go straight into training, but I thought it would be a really good opportunity just to practice the interview, because it is quite a competitive process. So it's good to have as much experience as possible, knowing that that wouldn't disadvantage me the following year. And if anything, it would put me in a stronger position. So I would definitely recommend applying this year, even if you aren't sure whether you want to take up that place.
Sure. And did anybody have a sense of the sort of competition ratios? I think that's what people were getting at, what it roughly sits at, or?
I've got to admit, I don't know the exact number. I think there's about 350 spots in the whole of the UK. I think that's how many we were ranked within. And within London, I want to say there's about 80 spots, sort of at the maximum end. I can't tell you how many people applied.
That's fine. Just moving on with the questions. Somebody recommended MCQ Bank. I think that was Namata. It's not one that I've heard of. How many questions does MCQ Bank include? I guess, Namata, you might just want to say a little bit about why you thought that was the most useful question bank.
But now, how many questions the bank has, I don't have access anymore to check.
Yeah.
If you contact them, I think they'll be able to tell you that. I just found that to be the most similar to the questions in the test. I think 2 or 3 of them were identical from the MCQ bank that I got asked on the day. So that was good.
Okay, great. Just moving on. How much choice or influence do you get on your training area? It's quite a broad question. I wonder if they're talking about sort of throughout the 7 years or the initial selection points of the trusts.
So if the question is sort of within the deanery, the hospitals within it, when you're ranking, it will tell you the particular hospitals for ST1 and ST2. So you rank the deanery, and say if there's sort of 17 in Northwest London, you rank what you want in ST1 and what you want in ST2. And bear in mind that now we're sort of moving towards people staying in the same deanery for ST3 as ST2 for the most part, so that you can act up as a reg in the same hospital. So for the first 2 years at least, you would sort of know where you are, and you have quite a say, at least in the ranking process.
Even following that, you do matching interviews at ST2 to say where you want to be from 3 to 5, and then you do another matching interview at ST5 to say where you want to be in 6 and 7. And when I did my rotation at West Middlesex Hospital in Northwest London, every reg that I worked with got their first choice. So I guess it depends more so on the deanery that you're in and how many trainees there are. But everyone usually wants something different, so it shouldn't be too hard for you to get the one that you prefer.
Sure. Thanks for that, Namata and Sarah. Do you know if there is an option to defer?
You have to declare that in the application. If you haven't declared it in Oriel, I don't think you can then ask to defer.
Okay, great. Quite a broad question. As all 3 of you have started as ST1s, what are some of the challenges you face so far? If anyone wants to talk about
I think personally,
Go ahead, Nayati.
I think personally for me, and this might be quite personal, my F2 rotation where I did 4 months in obs and gynae was very gynecology heavy. So I felt like I hadn't had much exposure to obstetrics. And what I found really difficult is day one itself, I was, you know, going to postnatal ward and going to doing sort of the antenatal day assessment. And I think sometimes there are different guidelines and different processes within obstetrics that you're not aware of unless you've done that. So for me personally, that felt like quite a step up. But the thing I will reiterate is that, you know, a lot of people when in ST1, they expect you to sort of come as clean slate. So even if you've had prior O&G experience, that's a bonus. But if you hadn't, at least where I'm working, the consultants are very keen to teach you everything you sort of need to know as an ST1. So they're happy for, you know, for you to ask lots of questions from the beginning, which is really good.
Okay, great. Thanks, Nayati. Just having another look. We can take probably 1 or 2 more questions. Just trying to pick something broad. In your experience, have you heard anything in particular about which deaneries have the best obs and gynae training?
I think that's probably a really difficult one to answer. I think all of our deaneries would probably say in the induction that their one is the best. And I know Marta, our deanery, certainly said that. So that's very difficult. I would say try and speak to as many people as you can in terms of trainees in the deaneries to get an idea. But I personally picked the deanery based on sort of what we discussed, family and things like that.
Would you advise doing MRCOG Part 1 during foundation training?
I think lots of people have asked me that, and I think that's very personal. I didn't do it. And you just have to look at your own CV and see if you think that there are enough things that you've done that show commitment to specialty. Because in fairness, in the interview, when you can't talk very much about having done it, all you say is I've done the MRCG Part 1 and I've passed. But the amount of time that you would spend studying for it would probably take away from time for you to do an audit or do another project, which you may be able to talk about in more detail to show interest. So it depends really whether you feel you have enough other things and whether it's worthwhile putting in the time for the MRCOG Part 1 or whether you want to build your CV in a different area. It's definitely not a requirement. And I think all of us, all the ST1s at my hospital, so Sarah, me, and there's one more, haven't done. Is that right, Sarah? Yeah.
Okay. And I think we'll take the last question. Are the deaneries that you guys had for your ST1 applications pretty much the same as the F1, F2 deaneries, or do they differ to the foundation deaneries?
I think they're mostly the same, to be honest.
Yeah, I think they are mostly similar. The only thing, for example, in Wessex for F1 and F2, you can be placed on the Isle of Wight or Jersey, whereas for obs and gynae, you would just be mainland, so you wouldn't get placed sort of Isle of Wight or Jersey. So I think there are some hospitals that don't have O&G within the deanery where you'd get placed essentially.
Right. Okay. Thank you so much. All 3 of you have just given us a lot of useful information. So thank you, Namata, Nayati and Sarah, for all of your input today. We have had a huge sort of, we've just been inundated with questions. So where possible, we're going to see if we can distribute your email addresses or other ways to contact you. And obviously this recording will be available as well. So thank you. That just ends the first part of our event today. We are running slightly behind on schedule. So we are going to be having a break and we will most likely be starting the second part at 4:30 now. But yeah, so feel free to go and have a break and try and rejoin. We'll be posting a new link for the second event and we'll be joined by some academic trainees and some F3 doctors as well. But yeah, thank you once again. See you all soon.